ladies and gentlemen, and really welcome to these special rounds today. On behalf of Kim Connolly and the Heart and Vascular Program, and Andrew Yan and myself and the entire team, it's really our great pleasure to welcome Professor Faiez Zannad today, as really he requires very limited introduction. I'm sure every one of you on the line knows of him and his work quite well. Professor Zannad is the Emeritus Professor of Therapeutics at the University of Lorraine. He's the past director of the Inserm Clinical Investigation Center, and also in 2019 was recognized as the Professor Eugene Braunwald Scholar at Harvard Medical School. He's had a profound impact as a clinical trialist and has really significantly contributed to the genesis of all of the data around modern heart failure drug therapy, and really has played a pivotal role in the development and translation of MRAs, beta blockers, and more recently SGLT2 inhibitors, and many other trials that are currently ongoing that have paved the way for the sort of four pillar therapies in heart failure with reduced and now preserved ejection fraction. I had the great honor of working with Professor Zannad on the Emperor program, and also more recently on some of the data with respect to finerenone in the fine arts trial. And we're working together on many different trials together as well. He's had many friends in Toronto that have worked closely with him, including our own Sean Goodman, who's on the line, who has worked with him, as well as Jay Udell, and many others at the University of Toronto have contributed on clinical trials alongside him and under his leadership. Professor Zannad has published just a few papers, 1,200 or 1,300 peer-reviewed papers, is a highly cited researcher, has received the 2014 European Society of Hypertension Paul Milles Award, the 2017 ESC Heart Failure Association Lifetime Achievement Award, 2022 Heart Failure Society of America's International Honorary Fellowship Award, and the list continues. So we are so delighted and really truly honored to welcome you, Professor Zannad, to our rounds, and we very much look forward to your insights, particularly as you sort of, your title tells it all, the story and the saga of mineralocorticoid receptor antagonists and their evolution into clinical practice. So welcome. We look forward to seeing you on a sunnier day in Toronto in person, as we were saying, and thank you again for doing this.
Thank you so much, Shubod, and thank you really for having me. And I would have loved being with you because, it's also freezing here in Paris, maybe not below 0 degrees, but it's really cold. So I would love to share with you today, indeed, this long story of the mineralocorticoid receptor antagonists in heart failure and CKD. And this is the story which is closest to my heart. I have been indeed involved in many other important foundational trials for heart failure, and certainly many of them came out of serendipity. Nobody was imagining that beta blocker would ever become heart failure medication, and same thing with SGLT2 inhibitors started to be just a glucose-lowering medication. I did participate in the very first CBIS foundational trial for beta blocker, and I'm privileged also for having been a primary investigator of Emperor. But the closest story to my heart is really this MRA, and I hope I will share some excitement with you. I will share with you some pathophysiological background and then, of course, review the clinical evidence of the major trials in heart failure, mostly in heart failure. I will certainly mention some of the CKD development, but I'd like to get focused on heart failure. And I will, of course, share with you some frustration of having implementation being so poor for the time being. Hopefully, this is going to be increased and improved. And of course, I will finish up by telling you that this is not only a saga, because the saga is the story which has been evolved and revolutionized, but now there are many new chapters to be written within this category of medications. So it all started actually when this first diagnosis was done of primary aldosteronism by Dr. Kohn, and the spironolactone was first introduced in 1960. So you can see it's a really, really long story starting the last century. And the FDA has indeed approved the spironolactone for hypertension. But in the early 80s, there was a very important seminal paper in Science which has achieved the cloning of human mineralocorticoid receptor and the description of the receptor itself. So the agonists and antagonists were known before the receptor were cloned. And very quickly, there have been just the use of this medication in hypertension. And for 20, 30 years, this was a sleeping beauty. Nobody paid attention to this medication outside of the primary hyperaldosteronism, which was mainly treated surgically, but then spironolactone was used only in hypertension. And very quickly, in the late 90s, it appeared that aldosterone is produced everywhere, almost, not only in the adrenal glands. It is produced in the heart. It is produced in the myocardium. And for some reason, and the heart is a paracrine organ because aldosterone could act on the heart, being produced in the heart. And then it has been shown that it is produced in multiple other tissues. And the understanding of aldosterone has evolved very quickly, just from simply a hormone, dealing with sodium, potassium, and water in the kidney to a real paracrine inflammation and fibrosis mediator. And since then, new medication has appeared from steroidal, like eplerenone, and then non-steroidal, and many more medications are being developed to mitigate this pathway. And the other very important progress over the last few years is the understanding of heart failure as a kidney disease as much as a heart disease. And by the way, very recently we are introducing the other consubstantial element, which is the liver as well. So the CKLM more than the CKM syndrome, whereby actually aldosterone plays a very important role in the heart, in the kidney, and I wish I had more time to share with you also the result of the liver and in what used to be called NASH, but now called MASLD. So these are the different progresses. And of course, concomitantly, this has been accompanied by many clinical trials, but actually, this was a great lesson of reverse translational because it all was prompted by this first conceptual paper that I've written in the American Journal of Cardiology, coming with the new conceptual framework, which led to the first heart failure trials, and then a cascade of many other trials. But within this, what really accelerated the whole area is the circulation paper on the mechanism of action of spironolactone in rats, and I will share this with you as an antifibrotic medication. And subsequently, there is a cascade of New England Journal of Medicine paper with all these trials that I will be pleased to share with you very quickly. This is just the historical perspective, and you see that it is a really saga started in the 90s, and we are still unfolding with many more chapters. And I have been very privileged to be the PI or co-PI of these many trials, which are highlighted in red here. So first story is about heart failure. And I told you that after being used as a hypertension medication, aldactone was used for what we used to be named dropsy at this time, congestion. And actually, it was used also in cirrhosis, in hyperaldosterotic states like intractable edema, whether it is in cirrhosis or severe heart failure. And this was the story at that time. But then in the late 90s, there have been multiple observations that high aldosterone levels is bad. And from the Consensus 2 trial, there was a very good depiction that elevated aldosterone was associated with poor outcome. But then at that time, we thought that if you mitigate the renal angiotensin system, it will block together because the cascade will be blocked high up in the renin, aldosterone, angiotensin level, and then aldosterone will be taken care of and it will drop. This wasn't true, and this we have highlighted this paper in our conceptual paper from Resolve and many other sources, showing that if you block this system, even with dual therapy, with enalapril plus candesate, and even though you may be adding a beta blocker, you may indeed, within the first week, drop sharply aldosterone levels, but after a couple of months, there is a rebound. And some people have called this breakthrough of aldosterone or escape phenomenon. And therefore, aldosterone is not controlled by any renal angiotensin system inhibitor. Still, at that time, in all textbooks, combining spironolactone with an ACE inhibitor was contraindicated. But then digging for information from consensus 2, we were able to show that actually, to find out actually that the many patients, half of the patients in consensus were taken spironolactone when they were exposed to enalapril. And these were taken at doses above 75 milligrams just for diuretic use. And these patients did very well. The prognosis was very poor, but they did benefit from enalapril combined with spironolactone. They did have more, worsening renal function and more hyperkalemia, but the benefit-risk ratio was very elevated. So this was the foundational principle of what we had as rationale for the RALS trial. That spironolactone, we need to block the receptor on their own, that taking care of the renin and angiotensin would not suffice, that aldosterone is effective in many other tissues, and mitigating aldosterone with an MRA is an unmet need in heart failure. Now, we have been also contributing to the progression of knowledge from these hyperaldosteronic states. I have shared with you the primary hyperaldosteronic states, which elevated aldosterone and low renin, and this is typically the Cohen syndrome. But many of them are actually not tumors, and there is primary aldosteronism in almost 15-20% of hypertensive patients, which may benefit from anti-aldosterone therapy. But there is also renin-dependent aldosteronism, whereby, like heart failure, where it is all the cascade of the stimulation of the renin-angiotensin system with the second A of the renin-angiotensin-aldosterone system being stimulated as a consequence of the hyper-elevated renin. But then there is other situation where aldosterone is normal, just not elevated, no hyper elevated, and you have still an excess receptor overexpression and activation, and this is the case in heart failure, obesity, diabetes, and CKD. So although aldosterone levels are totally normal, you may still wish to decrease it, and better, if you may wish, stop the activation with MRAs. And at the same time that we did RALS, we had this background knowledge from Carl Weger that aldosterone may promote inflammation and fibrosis. And this was really foundational for the RALS trial, independent from any diuretic or antihypertensive effect, just specifically targeting fibrosis and inflammation in the heart, the vessel, and the kidney. And at that time, after the first ACE experiment showing the antifibrotic, anti-remodeling effect of ACE, it was tempting to extrapolate what we knew from the ACE to the MR system and speculate that blocking the MR may also have antifibrotic effect. And this is, again, this background that we have done the RALS trial with Bert Pitt. And the brilliant idea of Bert Pitt is to select low doses. You remember the spironolactone was used at doses above 75 milligrams for antihypertensive and diuretic effect. And we have elected to select doses as low as 12.5 milligrams, which was chosen after an early phase 2 study showing that indeed there is a profound decrease in NT-proBNP. At that time, it was called NT-ANF. And this has conducted to the RALS trial with 25 milligram up titrated to 50 milligram if tolerated. And you all know that it was a lifesaver, 30% decrease in all-cause mortality in patients with low ejection fraction and very poor outcome. Now, from this trial, we had a chance to look at fibrotic biomarkers, and we measured collagen fragments in patients from RAS, just to show that patients with elevated level of P3 and P propeptide of collagen type 3 had a very poor prognosis. And we also had showed that spironolactone could decrease these levels dramatically in patients with a fibrotic profile with P3 and P above median, but has hardly any effect in patients with low fibrotic profile. So these are the same patients, very severe heart failure, but not all of them were fibrotic. And the beauty of this demonstration is that only patients with a fibrotic profile benefited from the treatment, and this subgroup etiology is based on the median level of different collagen biomarkers, P1NP, P1CP, whether C or N-terminal peptides, and P3NP. You can see in the blue lines here that patients with low level of collagen fragments had zero benefit. It's only the patient with had the elevated level of fibrosis which benefited, and you can see that the benefit was more than 30% overall in all population. It reached 50% decrease in all-cause mortality. So with this in mind, it has many people had get back to the bench trying to find out how this system works. And since then, it has been very well established that there is more than aldosterone story. There is also MR activation and overexpression, and this was very, very prevalent in a large variety of diseases, from cardiovascular, also CKD diseases, and very much involved in the pathophysiology of heart failure. So with this in mind, it was Novartis, and then it was Shell, and then Monsanto and Pharmacia who got eplerenone development over time. And we had multiple other trials with eplerenone, and I will share with you the rest of the trials with the mineralocorticoid receptor antagonists. Eplerenone was tried in heart failure with reduced ejection fraction. I will share with you the result of myocardial infarction later on. But in HFpEF, spironolactone was tried in TopCat, and you may be aware of the Fine Arts HF trial with finerenone in HFpEF. And you see the results here with the spironolactone on the left, eplerenone on the right, emphasis which with mild moderate heart failure, but still with reduced ejection fraction, and RAS in severe heart failure. And you can see very, very reproducible benefit of more than 30% decrease in the primary endpoint of composite CV death and heart failure hospitalization. So across two trials, a large spectrum of severity of heart failure with reduced ejection fraction, two different agents with one less selective and the other more selective MRA, we have very consistent result and very robust data from these trials, which has established MRA as among the foundational therapy in HFrEF, class 1A recommendation, and has been established just short before the latest chapter of neprilysin inhibition and SGLT2 inhibitor. And the good news is that there is an additional benefit of combining MRA and SGLT2 inhibitors that we have shown here in this meta-analysis. There is indeed some additional effect. I wouldn't say really synergies, but we may benefit from combining both medication, not only because the benefit is additional, but also safety is better. There is less hyperkalemia in patients who are receiving the combination of these two medications. For some reason, the mechanism of this protection against hyperkalemia is not totally understood. And this conceptual paper we have published showing that if you do a good job having all patients on guideline-directed medical therapy, including MRA, you may have a wonderful drop in mortality and a relative risk reduction of 73%, and number needed to treat only 4. And if you look at the data in this way, how long you can prolong the life of patient if they are offered all this medication together, you can see it can go any way between 4 and 6 years. Gift of prolongation of life, of survival, if patients are optimally treated with all this medication together, which is an unbelievable story. I can tell you, I'm not sure that in any other discipline you have this high level of evidence with this cumulative benefit of medication with such prolongation of life. Now, this is the story of HFrEF. HFpEF, you are very well aware about this story, a sad story, I would say, of TopCat, whereby the trial was kind of muddled up by the very low event rate in Russia and Georgia, because simply investigators have cheated and not really involved the real patient. They have enrolled very low patients and almost probably not heart failure patient. But what we did is another analysis from this trial, and you may remember that patients were enrolled on the basis they had a history of heart failure hospitalization or high BNP. And this randomization was stratified. So anything I'm sharing with you here is stratified evidence. This means very strong evidence. Now, if patients were enrolled on the basis of history of heart failure hospitalization, this is the trouble where the trouble came for. Many investigators decided that their patient had heart failure, although the hospitalization, index hospitalization, was not necessarily a true heart failure hospitalization because it wasn't ascertained necessarily as such. But if patients were randomized on the basis of high BNP, as you may see here on the bottom left, you can see that the trial was really positive and highly significantly so, with 35% decrease in the primary outcome with a p-value of 0.001. So I would like this trial to be remembered as a positive trial, and spironolactone is certainly a drug which is effective in HFpEF, although, of course, because this is based on the stratified analysis, the level of evidence was not convincing enough to make this drug become a class 1A, and therefore the recommendation, the guidelines of spironolactone is only class 2B for the time being. So until we had fine arts, which actually has beyond doubt proven the concept that MRA are very effective in HFpEF. And at least this trial is unequivocal because the evidence is high. And this was definitive, 6,000 patients with HFpEF randomized to 20 or 40 milligram. This is the first and single trial for 40 milligram. Please keep that in mind. All the trials before, including CKD, were only 20 milligram. I will get to that later when we'll talk about safety and potassium. And this fine art HF trial has randomized patients with HFrEF and HFpEF. And to make a long story short, the trial was significant with a p-value of 0.007, and you can see the primary endpoint was a decrease of 20 or 16% decrease of the primary endpoint. So we do have now a cure for HFpEF. In addition to SGLT2 inhibitors, we do have finerenone, and the combination of both works well actually in subgroup analysis, although the number exposed to both drugs together is low in both SGLT2 inhibitors and MRA trials. So putting the totality of evidence together from heart failure, whether HFrEF or HFpEF, like we did with SGLT2 inhibitors, across the full spectrum of ejection fraction, we do have evidence of persistent and consistent benefit of this medication, a class of medication. But there is some heterogeneity, and obviously the evidence is stronger, and certainly the benefit is larger in HFrEF than in HFpEF. But still, it is fair to say that it is simple to keep in mind that this class of drug may be effective across all ejection fraction, like actually we have seen with the SGLT2 inhibitors. And this is true for CV death as well. in HFrEF. The evidence is weaker in HFpEF because the power of these trials were lower and the event rate was lower. If we get to upstream to prevention now and preventing remodeling and heart failure post-myocardial infarction, we did the Ephesus trial in patients with acute myocardial infarction and some sort of left ventricular systolic dysfunction and or signs and symptoms of heart failure. And you may remember that this trial was also highly statistically significantly positive, 15% decrease in all-cause mortality. Eplerenone is just more selective than spironolactone with zero side effect when it comes to sexual side effects, but it is very similar to spironolactone when it comes to its property of mitigating MR. And very lately, from your countries, guys, this wonderful group of people have done the use of spironolactone in acute myocardial infarction, but no risk of heart failure because patients were not enrolled on the basis that they had heart failure or poor ejection fraction. So this is almost all comers. And the trial didn't reach statistical significance in the primary outcome, but there was benefit in the prevention of subsequent heart failure, progression to heart failure. So we still have some clue that the drug may be preventing heart failure post-myocardial infarction. And I have summarized the multiple post-MI trials with different MRAs. And you can see that there have been smaller trials with spironolactone albatros and with eplerenone. Reminder, the totality of evidence is that in high-risk patients with LVSD, left ventricular systolic dysfunction post-MI, you may benefit from progression, limiting the progression to heart failure and to death. In lower-risk patients, you may still have a benefit using an MRA in the acute phase, slowing progression to heart failure. And this is just a summary showing that at any stage of heart failure, the most severe cases from RAS all the way back to patients at risk of developing heart failure because of myocardial infarction, but also at risk because of CKD or diabetes. I will share with you now. And also from the HOMAGE trial, patients with hypertension, not symptomatic for heart failure, may benefit from spironolactone. I will share with you now. Now, this is Fidelity, which is a meta-analysis of Figaro and Fidelio, patients with diabetes kidney disease. And you can see that the best benefit was prevention of heart failure. Not so many patients with prevalent heart failure were enrolled. Actually, heart failure was not well characterized, and most patients did not have stage C heart failure. Maybe many of them had stage B, but the bottom line is that there was a profound 20% to 22% decrease in progression to heart failure and hospitalization for heart failure in patients with diabetes kidney disease when they were exposed to finerenone. Finerenone, which main feature is that it is non-steroidal and therefore had no sexual side effect. And it was developed on the basis that it has a balanced kidney and heart effect. And we'll see whether it holds true that it may be more kidney friendly and have less effect on potassium. And you can see here the other prevention trial that we did called HOMAGE. And these were patients at risk of developing heart failure, so to say stage B, because of diabetes, hypertension, or ischemic heart disease, but no signs, no symptoms of heart failure, the NT-proBNP below 100. And you can see within, this was not an outcome trial, but within this population, we were able to show that within the first month, there is a very sharp drop in NT-proBNP. There is a very sharp drop in collagen biomarkers, antifibrotic effect. And on echocardiography, you have a very profound anti-remodeling effect with decrease in left ventricular mass, decrease in left atrial volume, and improvement in filling parameters. So this is stage B patient, probably slowing progression to stage C, certainly on the conceptual framework of slowing remodeling and progression to HFpEF altogether because of the antifibrotic effect. Now, this is the evidence. We have a class of drug with multiple agents with more or less selective to MR and more or less selective to the heart, steroidal, non-steroidal, consistent benefit across a wide range spectrum of heart failure presentation and condition and diabetes kidney disease. Now, the issue is implementation. We do have a great level of evidence, and I really would like to share with you my biggest frustration is that despite this very high level, probably among the highest level of evidence among all heart failure medication, we have the poorest possible implementation. And you can see among all medication, the least implemented guidelines are those advocating the use of MRA. This is one of many observational studies, and there is reason for this. The main reason was this paper from one of your colleagues in Canada showing that short after rails, there have been an epidemic of hospitalization of hyperkalemia. And this paper made everyone crazy, and everyone was concerned about spironolactone altogether. I would like to highlight concomitantly, maybe 1 or 2 years later, there was exactly the same study in Scotland showing that there was not a hint of increase on hyperkalemia hospitalization at all at the same time after rails. And well, I'm sorry to say that this was a very harmful paper because subsequently multiple papers from the same group has shown that actually this was related, this excess of hyperkalemia was related to the fact that spironolactone was often prescribed to inappropriate heart failure candidates because of the presence of relative or absolute contraindication and very poor potassium monitoring. But this was genus was out of the Pandora box, and everyone was really concerned about that. And many has a concern about hyperkalemia and had this prompted to stop medication altogether. And you can see multiple studies showing that stopping MRA because of hyperkalemia was counterproductive and increased the outcome and the heart failure mortality in these patients. And we have done multiple educational efforts showing that hyperkalemia per se across all trials was here to stay, including in fine arts HF. You can see in red here, in all trials, there is doubling of hyperkalemia above 5.5, but the benefit to risk ratio was overwhelmingly positive. Hyperkalemia above 6 was really, really uncommon. And actually, we have one single death related to hyperkalemia among all these trials was in Ephesus in one placebo patient, by the way. So it's really important that we go over this exaggerated concern about hyperkalemia. And on the other hand, you have a reduced rate of hypokalemia. And this is very important because, you know, mitigating low potassium may be important and maybe one of the multiple factors explaining the benefit on preventing sudden death altogether. Now, what we also have seen, and this is Oli Vardenay who has done this analysis in RALS, but also we've done it equally in fine arts, that if you happen to have your patient at 6 or 5.5, if this patient is on spironolactone, as it is shown here in U-shaped curve, they do fare much better and have lower mortality than the patient with the same level of potassium if they are on placebo. So being on hyperkalemia on spironolactone is less bad news than being on hyperkalemia off spironolactone. And this has been reproduced in multiple other trials And it's really important to highlight this. And this is the same depiction of this demonstration in fine arts. Patients with hyperkalemia fare much better if they are on finerenone rather than if they are on placebo. And there have been multiple recommendations, including ESC and others, showing that we should not stop, spironolactone or any MRA. We should stop only if patients go beyond 6, and until 5.5, you may reduce dose, but not stop the medication altogether. And because hyperkalemia is predictable, it's preventable, it's manageable, it's reversible, you should not keep patient off medication for long, because you may be able to reinitiate therapy or reuptake treatment as soon as you have fixed the issue of hyperkalemia. Worsening renal function is the other issue, and this is just to show that patients with poor ejection fraction, as low as 30 milliliters per minute, do benefit from MRA therapy. They may need lower doses, and we have stratified the dose in emphasis, for example, to not go beyond 25 milligram of eplerenone if patient had low EGFR, and across the board, as low as 30 milliliters per minute. You can see it here in this figure. There is benefit if you confound all steroidal MRA, but in fine arts, we have evidence because patients were enrolled with EGFR as low as 25-30. So the benefit, including in patients with poor renal function, is consistent. Now, what happens if patients run into worsening renal function during treatment with a MRA? We have looked at this in the multiple trials we had done so far, and you can see that it is indeed bad news if patients run into poor renal function. But even in this patient, they keep benefiting from the MRA therapy. So patients with HFrEF who develop impaired kidney function and drop the EGFR below 30, until 30, they may benefit from continuation of MRA medication. So it is no reason to discontinue medication, because the benefit outweighs the risk in these patients. So these are really very important elements to highlight across the board in order to take advantage of these medications. And we have to change this poor implementation of this class of drug, because this class is really very important and effective in mitigating the risk in this variety of patients with heart failure and diabetes kidney disease. So this is just a summary of the role of MRA in heart failure, whether it is HFrEF, HFmrEF, and HFpEF. The issue of underuse is of concern, and I hope I have shared with you multiple ways to overcome this poor implementation and take advantage and make your patient take advantage of this medication. I would like to end up my presentation here with further development in this class of drug and the current clinical trial, but also basic science research. In this homage trial we have shared with you early on with patients at risk of developing heart failure, or so to say stage B, we were able to do proteomics. And at this first evidence from clinical data of the variety of mechanisms of action of spironolactone in this type of patient, we have been able to show that underlying mechanisms and mechanistic pathways as investigated by proteomics of extracellular matrix of inflammation were profoundly mitigated by this class of drug, but also other markers of cardiac remodeling, of hemostasis, of angiogenesis, and also of apoptosis. So there is a variety of pleiotropic effect, and it's unfair to keep thinking of MRAs as simple diuretics. By the way, at very low doses we have been using, there is hardly any diuretic effect, or only actually as anti-inflammation and antifibrotic. there are multiple mechanisms of action much beyond the inflammation and inflammation and fibrosis. And the other way to mitigate the system is, of course, to block it at any one of the level. And of course, there is some anti-aldosterone effect with ARBs and ACE and preludin inhibitors. But I have shown you that all of this is inefficient in the long term because there is this aldosterone breakthrough. And the best way to block the system is to block the receptors. Now, of course, you can decrease the level of aldosterone. This may or may not be effective. It may be effective because in the hyperaldosteronic states, but I have explained that many conditions do not have necessarily high aldosterone level. It is the receptor which is an issue with hyperexpression, overexpression, hyperactivation. And the aldosterone synthase inhibitor is one way, but cortisone is another ligand of the MR, and therefore, if you decrease the level of aldosterone by an aldosterone synthase inhibitor, you may, with some upregulation, increase the level of corticotrophine, which may increase the level of cortisone. And if the MR receptor is not blocked, you may end up by having excess activation of the MR. So this is one of the early limitations of aldosterone synthase inhibitor, but with more selective drugs, we may have some benefit. So in the class of MRs antagonists has been enriched recently with many drugs. Some of them are simple modulators like balcinrenone, which may have some advantage of preventing hyperkalemia. This has yet to be demonstrated. And you have seen finerenone, which is now a drug used in clinical practice. Ocedurenone has failed in controlling hypertension, and the program has been stopped altogether. And there are many competing drugs altogether running in this space. This is just to show the variety of MRA. But for the time being, there is some progress in the safety in terms of sexual side effect, no real progress in hyperkalemia because they're still here across the board with many of these drugs. But don't forget, this is very much dose related. And I'd like to finish up with the newest drug in this area, balcinrenone, which, as I mentioned, developed by AstraZeneca as a modulator, not an antagonist. And this modulation does not provide a full antagonism. Partial antagonist may be behind the benefit of no effect on urine electrolytes and maybe no hyperkalemia, as shown in early phase 2. And we'd like to see this, confirmed in phase 3. And finally, aldosterone synthase inhibitor, having reached sophistication to be very specific to the CYP11 beta 1, and therefore not necessarily producing excess counter-regulation of cortisone, and therefore potentially having consistent effect, anti-aldosterone effect. This is almost my penultimate slide showing the ongoing. So it's not only Saga, the Saga is still unfolding. Many more trials with balcinrenone and with bagdrostat and vigatrostat in heart failure and kidney diseases. And you see there are many more avenues. We're using the RNA track and microRNA antisense oligonucleotides like the anti-angiotensinogen RNA therapeutics, providing potential vaccination together against aldosterone, like we have it with PCSK9 and like we had it with angiotensinogen. So maybe we'll have more sophisticated ways of mitigating the system altogether. So Saga is a long story, as I said, but now the story is still unfolding, and we may be seeing next chapters, and maybe in 30 years, you will invite me and to explain further the downstream of this story. Thank you so much, and I hope I have not bored you with a so long Saga story. and I would be much pleased to answer any question, if any. Thank you.
Well, thank you, Professor Zannad. Amazing overview, right? And just incredible to see how it has evolved over time. So why don't we get questions? Professor Abramson, your hand is up.
Outstanding talk. Thank you so much. As an academic clinician, when we have environments where we have heart function clinics where we can send patients for quick follow-up, the use of evidence-based interventions becomes easier. Do you have any practical suggestions, because we all have in different countries broken systems, to follow these patients who we want to watch for hyperkalemia, even if they're on the right therapies? And I think that's one of the challenges, is the care gaps for prescribing and who can help watch these patients. Any thoughts on that?
Yes, monitoring is essential, and you're absolutely right. I'll get to that. But, selecting patients is really important, and sitting with the patient and explain potassium issue. I mean, nephrology do that all the time. I can't think of any colleague from general physician or cardiologist sitting with the patient explaining what are the fruits rich with potassium, what is the diet of potassium, and how to predict and prevent hyperkalemia. So this is number one. And of course, the dose is really important. But monitoring is essential to the point that we have tried, but we have failed into developing a monitor which in a prick on the blood, you can measure potassium, but others are succeeding. There are, at least to my knowledge, 2 or 3 companies who are trying to do in the sweat. Others are doing just as a watch, measuring potassium subcutaneously, and which may help, showing that hyperkalemia is not much an issue, and you can work it out. So yes, monitoring is essential, but simply doing what is in the guidelines, and this is largely ignored. How frequently you need to check for potassium is very efficient. If you apply the monitoring strategy we had in all trials, which has been very effective in preventing any serious effect related to hyperkalemia, this would work out in real life very efficiently.
Thank you. Any other?
Kim, I've got a question. First of all, Professor Zannad, thank you. That was just remarkable, just to actually see the sort of the beginning to where we are, and the story seems to, as you ended, it seems to just being, you're just getting started again, with some of the new therapies. But, one of the questions I ask you, as a sort of senior mentor in the field, is that, despite this wonderful data, the uptake of this class of medications has been poor, as you've mentioned, right? And I wonder if you have any practical suggestions or, thoughts around what is the best way, as a group of sort of specialists and leaders in the field, that we can overcome the inertia when it comes to the use of MRAs, because it just seems that we're kicking the tires repeatedly, showing that these are, life-saving drugs. But of all of the therapies, this tends to be, the least. And I agree with you that the hyperkalemia story is overdone in some cases. And in that paper you shared with us, we've had lots of discussions about that internally as well. But beyond continuing to educate people about the evolving field, are there other things that we should be doing systematically to try to get more people on MRA?
Well, I'm sorry to say that education is really essential, because there is nothing, exceptional about this. But the issue of education is a real one, because historically, you may remember that spironolactone had no sponsor, and so it was even not indicated at that time. And I can remember the FDA came to Bert Pitt and myself asking whether we would like to be sponsors so that people will be educated and there will be some pharmacovigilance. but there have been a real poor launching of this indication. And short after that, you may remember as well that eplerenone, the day or almost the day it was, the trial were positive, it was approved, Pfizer has decided to just scrap it and not, promote it and not educate anyone about it. So this class of drug had multiple issues, never been having one or more multiple sponsors behind in order to, promote education. And this tells you that actually promotion and education and dissemination from pharma is really important. We should not always be critical about marketing strategy. Sometimes, education and SGLT2 uptake, very quick uptake, is that we have multiple trials, but at the same time, multiple sponsors doing the education very profoundly. So it's really education. I am very privileged to share with you my thoughts today and just participate in this education. Now with fine arts and finerenone, maybe there will be more education. But again, I'm not very excited about the way that the Bayer is promoting the drug, trying to show that hyperkalemia is an edge and the drug produces less hyperkalemia. It doesn't. You have seen the data. Mm-hmm. We really need to make the point that we can live with hyperkalemia. It's not much an issue, rather than just denying it altogether, because this has led only to poor implementation.
Yeah, you led Emperor and the evolution of empagliflozin in HFrEF and in HFpEF, but quite frankly, when you look at the mortality advantage that MRAs have relative to other classes, right? The market share that SGLT2 inhibitors have garnished relative to MRAs doesn't necessarily speak to the mortality benefits that this class of medications have had. So you're absolutely right.
You are putting your finger in it. This is my biggest frustration, having poured actually multiple evidence, but still lagging behind when it comes to implementation. So implementation science is a complex issue, so it's part of monitoring education. But hopefully with the many more drugs coming on board, we will succeed into getting these drugs to have it is respected place.
I'm still the biggest fan of MRAs when it comes to resistant hypertension, right? They're just incredible, right? Therapies to add on to these patients, and it just really, it helps dramatically. And it was wonderful to see the prevention trial, right, that is ongoing. I think Professor McMurray is leading that one with I'm sure you're involved in that, and Scott and others, and I'm helping in Canada, and that is probably a really nice initiative to prevent heart failure for the first time, as opposed to sort of strategies to treat. And I think Beth is going to be involved in that trial as well from our team.
Yeah, it's very important. We have been treating hypertension, heart failure when it is prevalent, but the main challenge now really is prevent heart failure, because the incidence is still rising. So we need to mitigate heart failure at the very early stage of prevention.
Excellent. Well, if there's no further questions, we're coming up to 1 p.m. Eastern Standard Time. So just on behalf of the Division of Cardiology and the Division of Cardiothoracic Surgery and the Heart and Vascular Program, just want to say a huge thank you, Professor Zannad. I think, your comments, as always, are extremely important and valuable, particularly the hyperkalemia issue. This should not be a barrier. This is easily managed. It doesn't take a lot to do, but is been an interesting issue with this particular agent. But I think moving forward, we really do want to ensure, as I think Sabot was one of the first ones to create the foundational pillar type thing. This is firmly embedded in that pillar. So we, as clinicians, we need to use these agents for the right indications, and we know they have very profound benefits. So again, thank you for all your work over a very long time frame, and we're looking forward to having you back. Probably not in 30 years, maybe a little bit more sooner, okay? But we'll get you in. Yeah. We'll get you in person and in summer.
This year, yeah,
it's a bit nicer. Yeah, exactly.
And also thank you for all your help with, you've always been kind to Canadians on CBCT. Sean and I and Jay and many others, we look forward to that meeting. And, I think we all are very appreciative of the invitations that you send our way to be part of those meetings. It really means a lot to us to be there. So thank you.
We love you guys. Many of you are